Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of Inside JACC, bringing you the highlights of our forthcoming issue of JACC in the March 27th issue. And the first paper I'd like to tell you about is an interesting study that evaluated the role of dabigatran in patients undergoing ablation for atrial fibrillation as compared to warfarin. And in this study published by Laccaretti and Associates, the protocol called for patients who are on dabigatran to have the dabigatran stopped on the morning of the ablation and then continued as soon as possible thereafter, whereas the patients on warfarin had continuous warfarin therapy. And what they observed in this well-matched group of patients was that although the thromboembolic rate was essentially similar for dabigatran and warfarin, that is not statistically significantly different, although it was slightly higher with dabigatran, there were more bleeds with dabigatran. And so in fact, if you looked at thromboembolic events as well as bleeds, there was a 2.5 times higher incidence with dabigatran. Now, before we say that dabigatran doesn't have any role in patients who are undergoing atrial fibrillation, I do think that there needs to be better data, more patients, a randomized prospective trial. But at least for the time being, there is the suggestion that continuous warfarin therapy in patients undergoing ablation is a preferable approach. Now, a second paper that's in this particular issue deals with the issue of aortic regurgitation in TAVI. And we know clearly that 15 to 20% of patients post transcatheter aortic valve implantation do have aortic regurgitation, and it has adverse effects. And in this particular paper by Sinning from Germany, they looked at an aortic regurgitant index, which was the diastolic pressure gradient across the aortic valve, aorta minus LV, as a percentage of systolic blood pressure. And they found, in fact, that this particular index was very effective in identifying patients who had a significant aortic regurgitation and would have untoward events afterward, and that an index of less than 25 was of value in patients with significant aortic regurgitation just by usual assessment, echocardiography, et cetera, and even in those who had mild aortic regurgitation. And of course, this might be a value in indicating those patients in whom subsequent dilation or perhaps even valve-in-valve should be applied. The last article is really an interesting one because it deals with the value of a simple electrocardiogram, QRS duration, in predicting the outcome, particularly sudden cardiac death in patients with aortic stenosis. And this paper from the SEAS trial showed that if there was QRS prolongation of greater than 100 milliseconds, even in the absence of evidence of bundle branch block, that there was a considerable increase, 5-time increase in the risk of sudden death. Now, sudden death remained uncommon, even in the patients with the prolonged QRS interval, but this is a simple, inexpensive, easy test to obtain that may be of some value in risk stratifying patients. For Inside JACC, I'm Tony DeMaria.